Thank you, everyone, for connecting today. I can imagine that there's a lot of things that you could be doing in 1 hour, and for you to choose to be here with me today, it's an honor and a privilege. So, thank you very much for spending time with me. And as it was said before, today we're going to be talking about interdisciplinary treatment planning in implant dentistry. And we chose this approach of starting with single implants and going all the way to full mouth therapy and implants. So we're going to be tackling a lot of concepts and a lot of things. I'm going to be doing it fast because there's a lot of material that I want to be showing you. But hopefully, this is just an introduction for you to understand how everything works at Spear Education. And I want to say thank you to everyone in Spear because it really has been a very integral part of my training in the last decade. So before starting with Spear, I did my dental school at the university in Mexico City, and then I did my grad pros training at USC and a fellowship in surgical implant placement at the University of Louisville. So thank you to everyone for um, giving me the education that I have. And then I had the opportunity to go back home to Mexico City and partnering with Dr. Ricardo Mitrani, which I'm sure most of you have seen lecture or heard his name. He's a resident faculty at Spirit Education and teaches amazing courses over there. And thank you to all of our team. All of the work that you're going to be seeing here today is a work from many, many people. And this is just an opportunity for me to be here giving this lecture to all of you. If you want to reach out, ask any questions, or just stay in touch, Instagram nowadays is the best way of doing that. So I'm on Instagram as Dr. Jack Goldberg. And if you want to do it by email, just send me an email at jgoldberg@spiriteducation.com. So let's go ahead and start. As I said, we have a lot of material to cover, and we're going to be talking about single implants, couple of restorations in the anterior area, then a little bit more complex, combining teeth and implants, and then we're going to move to full implants. And we're going to be explaining a step-by-step procedure and how to tackle these cases, how to analyze them, and most specifically, how to communicate them, how to communicate properly within your team, and then to communicate with your patient. So we can see this result that we were able to achieve with a single implant. And as you know, in some cases, it's easy to get this result. In some cases, a little bit more difficult. And ultimately will depend on the anatomy of the patient and how they present themselves to the appointment and what was their etiology, what was the problem behind the missing tooth. But let's talk a little bit about guidelines. And as we all like to have a certain recipe or certain numbers, and let me tell you that it's very difficult to have a specific recipe. There are things that we do in every case, and there are things that we change to personalize each case. But let's talk about guidelines because that way we can really understand and think about these numbers. So I'm going to throw in a few numbers to consider. Again, these are averages, and that doesn't mean that if you don't have exactly all of these numbers that you're going to do the case, but I want to throw in some areas so you can start thinking about these concepts. So ideally, we would like to have somewhere around 1 millimeter of thickness in the buccal plate. Let's say we're extracting a number 9 and we're going to be placing an implant. We have to decide if we want to place an immediate implant or we want to have a delayed implant. So ideally, if we have all of these numbers in mind, it's going to be a little bit easier. So 1 millimeter of thickness of the buccal plate. Then once we extract the tooth, we want to have around 2 millimeters of buccal gap, and that's the space between the implant and the bone. 3 millimeters from the gingival margin to the crest and to the head of the implant. We want to have somewhere between 3 to 4 millimeters from the head of the implant to the proposed gingival margin. Ideally, it has to be 2 to 3 millimeters palatal to the incisal edge when viewed from this occlusal shot, and 1.5 millimeters to the adjacent teeth. So ideally, we want to have some safe space between teeth and implants. We're going to be talking a lot about different concepts. Most of them are based on the literature. Some of them are concepts that we have developed in our office together with my partner, Ricardo, and the whole team. But this is an amazing article if you're starting into immediate implant placement and provisionalization of anterior single implants. It's a great article to start. But let's talk about the sequence. Now, how do we do it? First thing we have to do is extraction. So we talk about what to look for from a radiographic standpoint, from a clinical standpoint, and what to look for during the surgical procedure. But the surgical procedure and the sequence would go like this. We do the extraction. We try to be as minimally invasive as possible. So try to be very, very careful when you do the extraction, because every bit of bone, native bone that you're going to be saving is going to be crucial for your final result. So then we use a surgical template. It could be analog or digital. I'm going to be showing both techniques today, and talk about advantages and disadvantages of each. Then we go ahead and do the implant placement as I explained before with those numbers in mind. Then we connect the temporary cylinder. Then we use a connective, we add composite to connect to that temporary cylinder. And then we use a connective tissue graft that's going to help a lot to prevent the bone remodeling. And that way is going to be much more predictable. Then we use a biomaterial to fill the gap. Remember that we talked about a buccal gap in between the implant and the bone. This is the area that we're going to be using the biomaterial to graft that area. Then at the end, we're going to be connecting the temporary or the provisional, and we're going to be explaining exactly how to do it. Now, before we jump into actual cases, let me talk a little bit about risk assessment and how to decide if we want to go ahead and do immediate implant placement or we'd rather wait. And let me tell you that both techniques are great. You don't have to feel bad if you're not doing immediate implant placement and you decide to do a delayed placement. It's absolutely fine, and it's a great service for the patient. So what to look for? We look for active infection. If we don't have active infection, we're on the green side. If we have active infection, we're on the red side. Then if we have a presence or an absence of the buccal plate, the SRP classification is the position of the bone from a 3D image. And this is based on Kahn's article, Joseph Kahn. Then if we have a low lip line or a high lip line, that's going to play a big role, because if you have a high lip line, you have to be very, very skilled and very careful in executing the whole procedure perfectly, because the patient is going to be showing any type of discrepancies. If we have a low lip line, it's going to be a much easier for that lip to conceal that area. Then we talk about the phenotype. Is it a thick or a thin phenotype? And the type of teeth. If you are working with square teeth, it's going to be easier to get a nicer result than if you're dealing with a patient with triangular teeth. So let's go ahead and start with the first case of today. She's a patient that came to see us. Actually, she's been a patient of the office for many, many years. And she had these crowns made many years ago in her office. But then she presented with a little bit of a problem, and she was concerned that the crown on that number 8 was loose. So when we took a radiograph and we saw there's a lot of resorption going on that area, and there was very, very, very little structure left to be able to replace the crown. So we decided to go through the whole analysis with her, and we decided that it was a hopeless tooth because it had structural damage, it had advanced decay, so it had recurrent decay around that margin, and it had inadequate ferrule because it was mostly only the post that was above the gum line. So with doing all of that analysis, we sat down with the patient, talked about it with the patient, and decided to extract the tooth and go ahead and do an immediate implant placement because we didn't have any active infection. We had a little bit of a buccal plate. It was not the best, but we were able to manage it. We had a low lip line, a thick phenotype, and squarish teeth. So as you can see, we almost had all of the parameters that were needed for me to be able to make the decision to go ahead and try to place the implant. And I say try to place the implant because we always tell our patients that we're going to try and do an immediate implant placement, and we're going to try and do an immediate provisional. And there's some cases that we decide not to do it during the surgery because the anatomy changed, because we didn't have enough initial stability, for example, or many other factors that we have to decide on the flight. So we always tell the patient that if we're not able to give her the immediate provisional, we have a plan B. So in this case, the arsenal that's needed for the surgery, we have a surgical guide is going to be analog. We have a tooth that we're going to be using a jig to reposition it. And we have that flipper in case we're not able to do the immediate provisional, the patient can go home with some type of temporary. So the first thing we do, as I said, is we're going to go ahead and do the extraction. It's very important to be as minimally invasive as you can. In my mind, there is no such thing as an traumatic extraction, because every type of extraction is going to be some trauma. We're removing a root. So we want to be as minimally invasive or as minimal trauma as possible. And we like to use this instrument. It's called the Benex extraction system. And the way it works is you're going to be using that. Remember that the patient had a lot of structural damage, so there's not actually, I mean, you don't have any space to use the forceps. So in this case, we go through the canal, and we're going to be using this special instrument, and it acts as a pulley. So it pulls the tooth in a vertical fashion, kind of like a corkscrew removal. That's the way it works, and it's absolutely amazing, and very, very little trauma to the soft tissue and to the bone. So we like to use this system. I suggest you to try it if you want to try and experience it. And then we go with manual drilling for the implant, and we use the analog type of surgical guide. And as you can see, we try to use the parameters that we talked about. We try to stay 2 to 3 millimeters away from that incisal edge in order for us to have a screw retained type of restoration. Then we connect the temporary cylinder. And in this case, we decided to use a patient's own crown. We were able to salvage the crown and use it as a temporary. That way we have all the shape, the shade, and everything was perfect, because this was the crown that the patient was using before. Then we go ahead and we go through the pickup, and we use composite resin, flowable composite resin for this procedure. And once we pick up the crown, we're going to be working in the laboratory to design and to groom what's called the subgingival contours, or the submucosal contours. And this is going to be critical because, as I said before, we're going to be using a double type of graft. So we use a connective tissue graft. Then in this case, I decided to use a membrane, a collagen membrane that's resorbable. You don't have to use it in every case, depend on how on what's the quality of the buccal plate. And then we use the xenograft to fill the gap. Once everything is ready, we connect the temporary restoration that's going to be screw retained. And then we're going to be using some sutures to have a coronally advanced flap. So this is 2 weeks after the surgery, and as you can see, everything is healing up nicely. Very important to be careful with the occlusion when you do this type of immediate provisional in the anterior area. You have to be very, very careful with the occlusion. Nothing can touch the provisional. Lateral, protrusive, excursive movements, nothing can touch the temporary. That way we avoid any type of extra pressure on the implants. And this is after we remove the sutures, and after everything is ready, 3 months, we wait at least 3 months for everything to heal and mature. And then we remove the temporary, and we start working on the soft tissue grooming. So as you remember, we had a lot of tissue, and that's a happy problem because we did the graft, and we also coronally advanced the flap. And that way we had a very nice result at the end of the 3 months. And we don't like to do any type of crown lengthening and remove tissue that was very difficult for us to get in the first place. So what we do is, by adding composite or acrylic to that cervical area of the provisional, we're going to be pushing the tissue up, so coronally, apically. And now you can see that we're adding a little bit more every 2 weeks. And then once we're happy with the final result, we're going to be duplicating that position using this very, very easy technique in which you connect the provisional to a an analog. Once you have that, you're going to use PVS material and you're going to duplicate those contours. And then you're going to be using this open tray impression coping with some GC pattern to duplicate that submucosal area and to make sure that we're able to transfer that information properly to the lab. Once that's ready, we design the final restoration, and that's a screw retained implant supported restoration that's going to be zirconia layered on the buccal area with a metal connection. It's very, very important to use a metal connection. And this is the final result. And as you can see, we're able to have a nice soft tissue result, and everything was blending very nicely for the patient. So let's go over the sequence one more time, now using the case that I just described as a reference and as an example. So extraction, we like to be as minimally invasive as possible. Then we go through the buccal plate assessment. So we check how is the buccal plate and we decide if we're comfortable placing that implant and what type of technique we want to use. Once that is inserted, if we're happy with the torque, the initial torque or the insertion torque, we're going to go ahead and modify and try in the temporary abutment. We go through the pickup procedure. Then we use the soft tissue harvesting technique from the palate or the tuberosity, and we graft that buccal area. It's very important to make sure that you position that in the exact area that you need it. Then we use biomaterials to fill the gap. We work on the contouring of the emergence profile of the temporary, and we go ahead and insert that temporary and make sure that the occlusion is perfect. So hopefully you're able to grasp a little bit of that sequence that we use. I'm sure there's many of you listening that are experts in immediate implant placement in the anterior area, but we like to be very methodical and very structured in the way we do things. So this is why we create these types of checklists and algorithms to make sure that we're trying to do the best we can for our patients. Let's go over to the second case, which is a little bit more complex. So this patient came to see us with a chief complaint of having been on an accident recently, and the tooth number 9 had a crack and was becoming very yellow. So we go ahead and take our x-rays, pictures and everything, and we see that that tooth has a root canal, and we see that there's a fracture. So first thing we do is a CBCT scan to assess where is that fracture. And as you can see here on the image on the left, that periapical image, you can see that there's a very, very clear fracture on that enamel portion. And we wanted to see how deep was that extraction, that crack line, to make sure that we make the right decision for the patient. So there's obviously two main things that you could do. One is extraction and implant placement. The other would be to do orthodontic forced eruption to try to bring that fractured line more coronal, and that way we can have a good seal and a good ferrule effect on that crown. So we went ahead and go through the different options with the patient. And as we analyzed the crack, we thought that it was going to be very difficult for us to go through the extrusion option, and the patient decided to go ultimately for the extraction and implant placement. So what we did is we went ahead and did the extraction. In this case, we're using a forceps and periotomes to be as minimally invasive as we can. And once we removed the tooth, we saw that the fracture was subcrestal. So we thought that it was a good idea, or it was a good option for us to go ahead and or looking backwards in hindsight, to have chosen the path of extraction and implant placement. So we go through the same process. We go through the drilling and implant placement. In this case, we're using a different type of implant that's a little bit more active, and that helps with initial stability, but we're still using an analog guide. And as you can see here, we try to nail as much as we can all the points that we discussed at the beginning. Remember, try to be 2 to 3 millimeters from that incisal edge. Try to be the head of the implant 3 to 4 millimeters to the proposed gingival margin. try to have at least 2 millimeters of gap distance between the implant body and the bone. And all those things are going to help with the final result. So we go through the modification of the temporary cylinder, and our protocol, as I explained, is always using connective tissue graft and a bone graft to fill the gap. In this case, it's a xenograft, so it's a slow substitution material that we like to use because we've seen in the literature that works best. And as you can see, we overcompensate. So we try to gain as much as we can buccally because we know that that's going to be having a very significant resorption. So if we add a little bit more at this stage, we're going to end up with a nicer result. So we decided to go ahead and use the immediate provisional technique as well. And once everything was well designed and polished, we went ahead and inserted that into the patient's mouth and use our sutures for the coronal lip position flap. And as you can see, 2 weeks for suture removal, everything looks very healthy. And again, we have a happy problem, so we have a lot of tissue, and that's going to be great. After 3 months, you can see that everything starts. We still have very good volume, but we don't have as much as we did the day of the surgery, and that's expected. And we go ahead and remove the provisional, and the tissue looks very nice, very healthy. We have a little bit, some particles of the bone graft on the soft tissue. That's normal. We usually just remove them with a topical anesthetic and make sure that we have a nice, healthy pink tissue in that area. And we take our initial impression and we start working on the temporary. Remember that in these cases that you have a lot of tissue, you don't want to remove tissue in the patient's mouth. So we go ahead and score the cast and create the ideal gingival architecture that we want. And we work on pushing the tissue by adding material. So as you can see where we were and all the material that we added, and this is more or less what you want to see in these cases. We put it in the patient's mouth and we start working on grooming that soft tissue. And every time we push a little bit more until we're happy. Once we're happy, we're going to be using this technique to duplicate the provisional and to duplicate the contour or the subgingival contours. That way we can create this personalized impression coping and support the tissue. We decided to also do a minimally invasive veneer for number 8 because on the temporary, we saw that we had a very wide space. So mesial to distal, we had a wider number 9 than a number 8. So we talked about this with the patient and we decided to do a veneer on number 8 as well. So we could match and have a little bit more harmony in that anterior area. We also did a crown on number 6 that was failing as well. And this is what we get back from the laboratory. This is a personalized abutment that we use for that patient. So it's a cast in gold, and then we use a zirconia crown that's layered. And this is the final result of the crown and the veneer. You need a very skilled lab technician to be able to match a veneer. It's a feldspathic, very, very thin veneer and a crown on an implant on the adjacent tooth. But I think our technician was able to get a very nice result. And this is what we got as a final result for the soft tissue. And as you can see, the veneer was already bonded and we were inserting the crown, screw retained crown on number 9. This is the final result. As I said, we try to aim for screw retention every time we need it. And as you can see, soft tissue looks healthy and we're able to get a nice result. Final radiograph. As you can see, we have very good bone stability as well. And a year after insertion, we still have very good bone on the buccal area, and everything seems to be very, very healthy and very stable. And we do see these patients for recall every 6 months for cleaning and make sure that everything is working good for them and they're taking good care of their implants. Because remember that most of our patients will always ask, how long will the implants last? There's a very, very nice article on Spear Digest I don't know if you've seen, but Spear has a digest that's amazing because there's a lot of contributing authors that do amazing articles for Spear Digest, and it's not like a traditional article. It's mostly like tips and tricks and things for everyday use in the office. So I find it very, very useful. And my partner Ricardo did an article talking about what he calls the biggest dental lie. And the biggest dental lie is that implants last forever. And a lot of dentists, unfortunately, continue this myth that implants are forever. And we always like to be very honest with our patients, telling them that nothing is forever. But if they take good care of their implants and their crowns, they're going to last longer than if they don't. So they come for recall. Now let's move ahead into the next case. I hope you're following up with me with my rusty accent from Mexico City, but I hope I'm being clear. And let's move ahead with our next patient. She came to see us. This is the kind of story that you have a 50, 60-year-old lady that comes to the office telling you that she neglected her dental care and her medical care because she was very busy raising her kids. And now that the kids are not home anymore, now she wants to take care of herself. And this is one of those cases that she came to see us, unfortunately, in a very, very bad and very critical condition of her teeth. She had infection. She had these temporary crowns that were done recently that were not very aesthetic and were not very functional as well. So it was a full mouth reconstruction and dealing with emotionally attached patients. It is difficult, and this is one of the things that we learn how to do. Not only how to treat patients clinically, but also how to treat them and how to accompany them through their emotional path and their emotional journey in our office. So, what we did in this case, we go through a usual analysis of pictures, radiographs, and mostly we wanted to work on the anterior area and on the maxillary arch. So we did these radiographs and started analyzing whether to decide. And this was not an easy decision because you could go both ways. You could do one option would be crown lengthening, do endodontics, again, root canal, use foundation restorations, provisionals, implant placement, and definitive restoration. So in a summary, saving these anterior teeth. And plan B would be extractions, so removing those teeth, bone reduction, because as you remember from those pictures that I showed at the beginning, there was a lot of it was a gummy smile. So when the patient has a gummy smile, you have to be very careful with where you position the transition line, and we're going to be talking about that when we move on to full arch cases and implants. So immediate loading, provisionalization, and at the end, definitive restorations. So the first thing we wanted to do with this case is to go through the diagnostic process and figure out if we wanted to do plan A or plan B. So once we did the diagnostic wax up, we went through a mock-up or an aesthetic prototype in which we show the result to the patient. And we can see here also from video, we take screenshots from video so we can have an active assessment of the lip line and the smile line. And as you can see, we decided to go for option A. So we wanted to save those teeth. So we went through the process of crown lengthening, and it was an open flap crown lengthening because it was a lot of structure that we needed to get, and we had very good keratinized tissue, so we were comfortable using this technique. And this is what we have. A few weeks after the procedure, we made new temporary restorations for her with a little bit better proportion and shape of teeth, and she was extremely happy with that result. Then we went through root canals, post and core, foundation restorations, build up, and all of that. So I skipped that part straight to implant surgery. We used computer guided implant surgery for this case, and we're able to do 3 implants on the right side and then 2 implants on the left side with a bone graft and graft also on the maxillary sinus. Now, after 3 months of allowing time for osseointegration, we went ahead and took impressions of the patient's implants and crowns. But as you can see here, if you remember correctly, I said 2 implants on the left side and unfortunately, we lost one of those implants. So let me tell you that there's no perfect practice, and if you place implants, you're going to be losing a certain amount of implants, and if you do crowns, you're going to be losing some crowns as well, and if you do veneers, some are going to crack. So there's no perfect world. And the idea of us joining together in a place like Spirit Education is to be able to share our failures and to learn from them and to show what we did to overcome those failures. So we lost an implant, but the patient was already tired of using temporaries. So we had the idea of going straight to the final restorations and only doing a temporary on that implant cantilever from the implant that was well integrated. And that way we could more or less finish the case from the anterior area that the patient was ready to finalize. And we replaced the implant. You can see now we have an implant over there in that area. And once that implant was ready, we just worked on those two implants as a smaller unit. And this is the final result. As you can see, we have the root canal, the implants, everything is well integrated, and we were able to transition the patient from having very poor aesthetics and very poor function to a more acceptable result in regards to aesthetics, but mostly to function and for her to be able to get her life back in order. Now let's go ahead into the final two cases. It's going to be a maxillary arch on implants and a bimaxillary, so both upper and lower on implants. So we're going to be talking a little bit about implant design, restorative design, prosthetic design, but we don't have a lot of time, so we only have 1 hour today. So I'm going to be throwing in a few concepts. And again, if you want to read more about these concepts, there's a lot of great stuff on Spear Digest from many authors that talk about these concepts, and also great online courses that go through. For example, there's a great course that talks about the LTR classification that we wrote an article a few years back in which we talk about how to analyze a full arch case on implants and how to use the LTR, which is the lip tooth ridge classification, to decide if you're going to go for a hybrid, metal ceramics, zirconia, if it's going to be 4 implants, 6 implants, like all these questions that sometimes come up when we're dealing with these cases. Everything is very well explained over there. So how do we ensure a smooth transition from point A to point B to point C? And when we talk about communication, we have to understand that the communication is one of the most difficult parts of our interactions in an everyday setting. Like, to me, it's much more difficult to be able to communicate properly with a patient than to do a technical part of the procedure, like placing an implant. That might be easy, but communicating properly with a patient or communicating properly within ourselves as a team, that becomes very, very challenging. So I'm going to be showing you a very linear process on how to treat these full arch cases, and hopefully that's going to help you in your office. So this patient came to see us and she said, I hate long teeth, and I had a crown. I'm sorry, I had a bridge, a fixed partial denture that came loose, and I am very, very uncomfortable. So that left side of the fixed partial denture was completely loose. And as we removed that bridge, we see that there's a lot of damage underneath those crowns. And this is one of the patients that comes to see us as an emergency, and they always say like, oh yeah, I came recommended by Mrs. Jones, and it's a 5-minute appointment. I just come here for you to re-cement the bridge that came loose. And you think it's going to be very easy, and once you take it out and you see what's underneath, then this is where the communication process again becomes very difficult. So as you can see, the first thing that we notice is that the papillae level and the gingival margin level is completely different on one side compared to the other. And if you remember, the patient's chief complaint was that she hates long teeth. So we do periapical analysis, 3D analysis as well, and we come up with basically two solutions. So those crowns, those remaining teeth were absolutely hopeless. They had root canal problems. They had periapical lesion in the molar, very minimal tooth structure. So we decided to extract those teeth, but then we came up and with two options. One was a unilateral implant-supported fixed partial denture. And the second one would be a full arch fixed partial denture. And it could be a little bit of an aggressive solution, option B. So what we tell the patient is, let's start by you understanding what that means, because a full arch solution on implants seems very scary for many patients. So this is where we use the patient education videos. These are amazing. I think there's over 240 videos right now, and I can promise you that we use them in our office every day. And the beauty about this is that, number one, for us dentists to try to explain something, we tend to overcomplicate things, right? We always say like, oh yeah, you have this pneumatized sinus and we need to do a bone graft that's a xenograft that blah blah blah, and so many implants and grafts, and the patient really, they don't understand. So these are videos that are like expertly produced. They're like a minute to 2 minutes maximum, so minute and a half mostly. And we show this to the patient and we tell her, this is what a fixed hybrid looks like. This is the way we would look if we place 4 implants or 6 implants. And they have amazing videos on how to use, like, for example, post-op, like how to clean these dentures. And you can send the videos to the patient's email and they can see them at home. So we go through this procedure with our patient and we go through the thought process of analyzing, like, what are the main factors that we should consider? Is the assessment of the remaining teeth, what's the patient's chief complaint, the expectation of the patient, and the finances, of course. So there are some cases that we're not 100% sure on whether we go for A or B. So what we recommend to this patient is, let's start by removing that breach that you have on your remaining teeth, and let's see what we find, because one thing is that we're very limited to what we can see from the radiograph. So we tell the patient, let's remove everything and we analyze what we find. And once we saw that, we saw there was a lot of inflammation, recurrent decay, and there was a lot of problems on those teeth as well. And if you remember the patient's chief complaint, the gingival levels are a big problem. So if we only place implants on the left side, we're going to end up having a big difference on gingival levels and papilla levels. And this is something that the patient didn't want. Remember, she hated long teeth. So we went through the whole process with the patient, explaining her what is a transition line. And let me tell you that the transition line is that junction of the prosthesis to the remaining ridge. So we want to make sure that we hide that underneath the lip. And as you can see here, in order for us to do that, we would have to place deeper implants to make sure that we hide that transition line below the lip line. So we had a few discussions with the patient and we decided to ultimately go for option B, so removing the remaining teeth and placing implants, 6 implants on the maxillary arch. In that way, we were able to be more predictable with that transition line and to be able to give her like more proportionate looking teeth and more aesthetic teeth to what she wanted. So we went ahead and did the full digital workflow for this case. So we didn't even take an impression. It was only a scan and a CBCT. And we planned for 6 implants and we get these back from the laboratory. In this case, we're using Smile in a Box. And we get these initial guides. We have bone reduction guides. So we went through extraction, bone reduction, implant placement, and ultimately the pickup of the provisional. And that part of the pickup becomes very easy because you have those pre-drilled holes. So it becomes much easier using this technique comparing to older techniques where we had to use a immediate denture and then pick up that immediate denture. So you can see the radiograph here with the 6 implants a few weeks after the surgery. And once everything healed very nicely, we were able to take our final impression and work on a first and a prototype that's going to be used a few weeks or a few months, depending on the patient. And that's going to be also used as a provisional, so the patient will take it home. In some cases, we try it on and make a few adjustments in the office and send it back to the lab. But in some cases, we want the patient to use them. So in this case, the patient used the prototype for a few months. And once we were happy, we converted that into a zirconia prosthesis. And for these cases, we like to use very, very minimal layering. So only a little bit of layering on the buccal area of the prosthesis, and everything else is monolithic zirconia. That way we avoid chipping and we avoid problems in the future. And as you can see, we can have a very, very nice result. And this is the final result. We're able to give the patient smaller looking teeth, more triangular, and hiding that transition line. So as you can see, this is a final picture of that patient's prosthesis. This is where we started, and this is where we ended up with that case. And she was a very, very happy patient at the end. Now let's move ahead to our final case so we can have a few minutes for Q&A. Remember that there's a Q&A section on Zoom, and you can just go ahead and type in your question there. And at the end, I'm going to go over the questions and try to answer them for you. So let's go over to this final case. This patient came to see us. She was complaining about not being able to chew properly, and we can see why. There was no posterior teeth on the maxillary and on the left side of the mandible. And of course, aesthetically, she was not happy at all. She used to smoke a lot. She stopped smoking right when she wanted to start dental treatment, but there was a lot of damage already made, and there was a very, very poor oral hygiene at home. So we go through our analysis, pictures, radiographs, periodontal analysis, and we see that there's a lot of bone loss around those teeth. There was a bleeding on probing. There was a lot of subgingival calculus, and there was a lot of mobility as well. So we decided to remove the remaining teeth and go for a bimaxillary implant supported restoration, placing 6 implants in the maxilla and 6 implants in the mandible. And this is the whole process that we go through when we're dealing with a digital approach. So we have a 3D, so it's a CBCT from the patient. So that becomes exported as a DICOM file. And then we have a 3D intraoral scanning of the patient, and that becomes an STL file. And we merge those two files, the DICOM file, the STL file, and the picture of the patient's face. And with that, we come up with this final plan in which we decided to place 6 implants in the maxilla, 6 implants in the mandible, and go for an immediate provisionalization, immediate function on both arches. So as we can see, we go through the analysis of every guide step by step, and this is again done with Smile in a Box. And once we are happy with the final result and we authorize the case, this is what gets sent to you from the laboratory. You have an initial guide. So number 1 is going to be your stabilizing guide for the pins. Then you have a bone reduction guide, which is a second one. The third one is your implant guide for implant placement. And the fourth one is going to be your provisional that's going to be connected to those temporary abutments. So let's go over one by one on the clinical case. So we use the remaining teeth to stabilize the initial guide, and we drill through those holes in order for us to put pins. Those pins are going to be stabilizing pins. And as you can see on the second guide, all that excess bone that we have above the guide is going to be removed to create space and to have that transition line hidden below the lip. So as you can see here from these occlusal shots, we go through the bone reduction guide and the implant placement. And once everything is placed, we go through the pickup process. We pick up those temporary cylinders and we adjust the occlusion. This is the radiograph right after the surgery. And as you can see immediately, the patient is still swollen from the surgery, but she was very, very happy with the result. So we can go from a tooth-supported failing dentition to an implant-supported prosthesis on both arches. And once we're happy with that, after 3 months of everything healing up nicely, we're going to take final impressions and we're going to go through the digital world one more time. And we're going to be designing the aesthetic provisionals that the patient is going to be using for a few months. So as you can see here, we add a little bit more characteristics to those teeth. We add a nicer looking pink and we check occlusion, phonetics, aesthetics, make sure that everything is nice. And once everything is working out nice for the patient, we're going to be going to the final ceramic reconstruction. As you can see here, again, we go through the decision of the material and the prosthetic design with the laboratory technician. But more and more, we are using zirconia, either full monolithic or minimally layered on the buccal. But nowadays, we're going more and more to fully monolithic stained zirconia prostheses and implants, because that way we eliminate the possibility of chipping, and the maintenance on these cases are less and less problematic if we use that prosthetic design. And this is the final result for that case from the laboratory. And as you can see, very, very nice looking teeth with a nice looking shade. This is work by my friend Domenico Cascione in Los Angeles, and beautiful, beautiful prosthetic reconstruction and final result where we have very stable bone levels and everything looks nice. And as I said, what's important in these cases is not only the day of the delivery. I remember Dr. Winston Chi, my program director at USC, used to say that the delivery date of these full mouth reconstructions and implants is the start of the treatment, because this is where we actually need to follow up with the patient, go through oral hygiene instructions and follow-up appointments, and make sure that everything we did uh, with a lot of effort and all of our heart is going to be in the patient's mouth for many, many years. And with that, I want to thank you for tuning in today. We're going to be having like 10 minutes for Q&A. So if you have any questions, go ahead and type them on the Q&A area. If you have any questions that pop up after today, you can always look for me on Instagram or email, or even on the chat on Spirit Education. Once you join, you can always send me a message there as well. So while we're gathering all the Q&A, and also you can take a few minutes right now to ask the questions in the Q&A section. I want to thank you also for joining us today. But before we move into the Q&A session, let me go back to what Spear offers. And as I said, I've been working with Spear Education for around 8 years now, and it's really been a transformative decision for me as a person, but for our office and our group. So you can enhance your clinical skills with Spear Online. As I said, there's many, many things to Spear. One is the Spirit Digest, that it's amazing, and we talked about these are like short format, very clinical articles from contributing authors. There's Spirit Online, which is like a ton of courses from Frank Spear, Greg Kinzer, Ricardo Mitrani, Darren Dister, Jeff Rouse, and many amazing clinicians from different types of topics. And also, there's a ton of like online courses. But if you want to be like more on a hands-on, you can attend the workshop, so you can meet all of these amazing faculty, but like see them live and go through the workshop. So you can explore more with Spear. There's again workshops, online courses, digest, study club modules, like a ton of things that you can use and decide what path you want to take. But it's amazing. Look it up, and I'm hoping that you'll find that useful, and you can talk to Spirit people and they can explain a little bit more in detail. But I think let's go ahead and answer some questions, so you can go ahead and continue the rest of your beautiful day. So Jerry, I'm going to go over the questions here, if that's okay with you.
Yeah, yeah.
Perfect. So okay, so first question, could you please repeat what was the extraction system? This is the first time I've seen that. It was so cool. Thank you. Yeah, it is very cool. It's called the Benex. So Benex, Benex extraction system. I think it's sold by Masinger in the US. But if you type in Benex extraction system, you'll find it on Google. Then next question from Fresh, do you use the Benex instrument for all extractions? To be honest, the answer is no. I use it for all of the difficult extractions where we don't have any remaining root tooth structure, like where we don't have any crown left. I love the Benix because it's very easy. When we have a tooth that has like periodontal problems, it's loose, we have mobility, or something that I can use the forceps or the periodomes, then I go ahead and use that. Try to be as minimally invasive as I can always. Then let's move on to the next one. The LTR classification, where is it detailed? We published an article, and I say we because I'm one of the authors. I think it was 2017. So you can look it up online on PubMed. Just click LTR classification and Goldberg, and you'll find it. I don't know if probably Jerry, we can send them the PDF by email after today's lecture. I'll send it to you, and if you have the database and can send them the PDF, that would be great. And also on Spear, there's a ton of explanations and our online courses, and on Spear Digest, there's a ton of articles explaining like what is the classification all about and how to use the classification when you're dealing with these full arch cases. So hopefully that helps, Presh, and you can look it up. Then next question from Robin, what is the name of the instrument used to remove that tooth root? Again, that's a Benex extraction system. So we talked about that already. Then can you discuss how you perfect and adjust the occlusion with an implant supported fixed dental prosthesis? That's a great question, Curtis. And it's not easy. Let me start by saying it's not easy, and there's a lot of like trial and error, and you have to try in the patient's mouth. What we do is nowadays with digital technology, we're able to copy mill. So what we do is once we have that first set of provisionals that the patient used already for 3 months, we adjust directly the occlusion on that prosthesis along those 3 months to make sure that everything is as stable as possible. Then what we do is we take an initial record and we take a scan, a duplicate of those provisionals, and we send that to the laboratory. So the laboratory will fabricate the aesthetic prototype that we're going to be using as a provisional for a few months using that occlusal scheme. And we go for canine guidance. I know there's a lot of people that talk about different types of occlusal schemes, but when we're dealing with implants on implants, we like to go for canine guidance and anterior disocclusion. And again, we tested for a second time on that provisional restoration, and we make adjustments, and we ask the patient to use it for a few months so we can see the wear pattern and we can see how the patient is doing that. Once we're happy, again, we scan it one more time and we send that to the laboratory. So that final STL file is going to be what the laboratory will use for milling the zirconia. And ideally, when we're dealing with monolithic zirconia, we try to do as minimally adjustments as we can on that final. So it is very important to go through the process of adjusting the occlusion before you move into that final one. I hope that was a little bit clear. There's also a very nice occlusion workshop on Spear, and there's a ton of Spear Online material on occlusion, so you can look that up if you want as well. Then the next one, how do you determine if the patient needs 2, 4, 6 implants for an all-on-X? That's a great question. And again, sorry, we don't have a lot of time today to go over our whole algorithm and how we think about these cases, but we mostly use an algorithm that we designed. We use the LTR classification as part of that decision. We use the EFSB, which is also taught at Spear, aesthetics, function, structure, and biology. The location, so if it's upper and lower, both or only one arch, the finances, and the compliance. So we use those 5 aspects to make that decision whether we go for 2, 4, 6 implants. Again, a ton of information on Spear Online, so look that up, and I'm sure you'll find the Spear Online course by Ricardo Mitrani that talks about it like step by step, and hopefully that will help you make those decisions in your office. Next one, do you recommend removing full arch prosthesis every 6 months at recurrent appointments to clean around the implants in the office? That's an amazing question. And I had a professor when I did my MBA that said that every good question, the best answer was always, it depends. And I know that sounds very political, but it depends. So our protocol on the office is we remove that every year. So we see the patient every 6 months for like traditional cleaning, like prophy, and we use the Cavitron system, and we go through ultrasonics, and we clean around with a super floss and all of that. And every year we do remove it, clean it outside, disinfect it, see if we need to change the screws, and we do that every year. But again, it depends. Some patients, everything looks perfect at a year recall, so we do it every 2 years. And some patients are not able to clean properly at home, and we do remove them every 6 months. Can you show again the initial immediate implant precision requirement diagram? I don't think we have enough time to go back to the presentation, but I can send that to Jerry as well, and he can send you that image if you like, or you just send me an email or a message on Instagram, and I'll send that to you as well privately. And then the last one from Jessica, beautiful presentation about, thank you, Jessica. I'm glad you liked it. About how many visits did your final case take to complete? Thank you. Wow, that's a good question. With these digital cases, we go much faster. So I would say initial appointment to take all the data collection. Then we see the patient for treatment planning. So that would be number two. Once everything is approved and finances and everything is taken care of, we go to the third appointment, which is surgery. And I would say follow-up appointment for surgery, but I don't know if you count that, if you will count those as uh, visits, but it would be surgery, then a few, like two appointments for follow-up, or even three along those 3 months. And then we do records. We send them for the aesthetic prototype provisional, so that's one more. And then we allow the patient to use it for a few months, and then final insertion and final adjustment. So somewhere between 6 and 8, depending on how many times you want to see the patient and how difficult patients they are, as you know. Um, what was the xenograft you used? I used BIOS mostly. So BIOS or Interos are the two companies that we use for xenograft. But any good company that has good data and literature will work nicely. And Priyanka, thank you for all the great information, great presentation. Thank you all for being here. I think that was the last question. So thank you for being here, and hopefully we can meet again in one of those Spear courses, Spear Summit, or someplace we can meet again. If you see me, come by and say hi, and thank you very much for spending this hour with me.